everybody. Good evening and welcome to the session. But finally, we are here today to discuss about the importance of 2D echocardiography in diagnosing cardiac pathologies. I'm Dr. Shravani Reddy. I handle clinical operations for Medvarsity. Joining me on the other side is Dr. Sajida Parveen Khan from Apollo Jubilee Hills, Hyderabad. She's the senior echocardiography consultant working with the cardiology department closely for a long time now and has also been our trainer for the 2D echo program. Welcome, Dr. Sajida. It's a pleasure to have you today.
Thanks, Dr. Shravani. Thanks for inviting me.
Thank you very much, ma'am. It's indeed our pleasure. There's nobody else better who can address this session. You've been there for a long time. You've been doing the thing and you've been training students. So I hope all our participants today will be benefited from your discussion. So for all the participants, I'd just like to address all of you guys. You've been typing in the chat box, Dr. Vanita, Saujanya, Meetdeep and all. Thank you so much for waiting. Let's go ahead with the discussion today. All of us know the basic idea of what an echocardiogram is. It's an ultrasound diagnosing procedure wherein high-pitched sound waves are used in order to pick up the echoes and bounce back on different parts of the heart so that we can study the functioning and the pathology of the heart. So there are different uses diagnostically that we have of 2D echocardiogram, but we'll dig into a deeper discussion today now that we have the faculty expert today. So Dr. Sajida, can you please address what this 2D echocardiogram is all about and why is it mainly performed in your department?
Yeah, these days 2D echocardiography is a basic investigation. It's very important now. I mean, in previous days and all, echocardiography was not of much importance. But now, since people are aware and new technologies and this, there are various modalities of 2D echo. It's not only 2D echo now what we are doing. We have again higher this like stress imaging, strain imaging, and transesophageal echoes, contrast echoes, and they help in the diagnosis. It's
Right.
it's not like, what should I say, just an investigation. It is an important investigation.
Right now. So, Dr. Sajida, in a practical perspective,
CBP of medical, it's echo is for cardiology. As CBP is for medicine, echo is for cardiology.
Right. Dr. Sajida, in our day-to-day clinical practice, now all of us understand the moment a patient comes with a complaint, anything related to cardiac, a basic chest pain or breathlessness or anything, it's a usual occurrence in the ER also. The first thing that we do is tie up an ECG and get an ECG done. The second thing that we can immediately think about is an echocardiogram. Today, that's what people think. Even before thinking of a troponin, people talk about get an echo done. That's how common it has become.
That's right.
But as a clinician now today, but if I remember my student days, not many of us are aware when we get out of the medical school what echo is all about. We know what an echo is, but then when to take an echo, when it is not needed, how to interpret an echo, or for that matter of fact, how an actual echo looks like, what a normal echocardiogram is. These are some things which we are not taught as students. But when we pass out of the medical school, we join a hospital as a medical officer or a doctor, this becomes an expectation from us that we are expected to interpret the reports, which is very difficult without any proper training and guidance, which we do not get at undergraduate level. So let's talk about this, Dr. Sajida. Why is this 2D echocardiography understanding and training important for every doctor?
See, basically, every doctor should know what is a 2D echo, like why it is done, what is the interpretation we are getting from it. Like it's the cardiac chambers, it's the function. There are different functions of the echocardiogram. Like there are a variety of modalities. Like the LV function, the RV function, the fluid status of the patient, the chambers of the heart, various diseases, like everything, right from valvular heart diseases, ischemic heart diseases, cardiomyopathies, pericardial diseases. All these sorts of diseases can be found by echocardiogram, right? So now once a doctor, like if he can interpret a report of a 2D echo, the echo may seem like, okay, it's just like people may not know like what is diastolic dysfunction, what is normal LV systolic function. Like the other day I had a patient who came with a diastolic dysfunction. I mean, mean, it's nothing. It's just the relaxing ability of the heart. But when that person was reading that report, like diastolic dysfunction, they were panicky, like what, something is wrong with my heart. Okay, so these basic things, even as a doctor, even the doctor called me up and says that there is a diastolic dysfunction in the report. Which, I mean, like for us, like a cardiologist and all, there's nothing to panic about it, like diastolic dysfunction, grade 1 diastolic. But when it comes to the doctors, like who don't know about the 2D echo report, or the patients who don't know about the report, it becomes panicky. So these are the basic things like a physician should understand.
Right, ma'am. You made a correct mention, Dr. Sajida. Different specialties and different departments work together in a healthcare. For example, in a super specialty like Apollo, you work with many departments together and you get a lot of referrals and many 2D echoes are performed in a day. But essentially, as a physician or as a neurosurgeon or somebody sitting in a different department, it becomes probably difficult to identify the specific things that are mentioned, the ejection fraction, where should we panic and where should we not. And it is different for different patients with different comorbidities. And that understanding, I don't think all of us have.
After the training, I feel that once you are trained and like at least you have a basic knowledge about an echo, like how it is done, what are the chambers. Like you can see even in the post MBBS people who come in and all, they basically don't have an idea like what is flowing from where and how. Like, okay, it's not that everybody should know it and all. You know the physiology, but some things are there. Okay, how many pulmonary veins are there? So most of them may not know it. These are the things like you need to be trained for, like where is the flowing from. And then in echo we have a color Doppler. We have a color Doppler where it shows blue and red color. Okay, so what physicians understand is blue means deoxygenated blood, I mean red means oxygenated blood. That concept is wrong. That you will understand only after knowing. It's not that I'm trying to point out somebody, but most who come to me for training, like even the other people, even if they are MDs, post MDs or anesthetist and all, they don't have that concept of color Doppler, like what is happening where and all. So right. These are the basic things like where you have to learn, you have to take a training into it.
Right. So, ma'am, you've been training our students for quite some time now. And usually we tell people that, any physician or a clinician getting into practice or already in practice, if you've never been formally trained in a 2D echo, please do consider doing this training. But most of the times the wrong assumption is people jump to the question that, what will I get to do once I do the training? It's not about what will they get to do or what will they become after it, but it's more about what they learn which will make a difference.
Yes.
So please tell me, ma'am, what is this 2 weeks clinical attachment that you do with the students?
In this 2 weeks, what we basically do is every day from 9 to 10, we have a theory class. Like theoretically, we teach them like what are the chambers, where how the blood flows, and what we have to look for. And in this 15 days, like we cover all the valvular diseases, ischemic diseases, everything. We try to cover all the echocardiography in this 15 theory classes. So from 10, usually our work starts from 10. So from 10 to 5, we have dobutamine stress echoes, we have transesophageal echoes. They can do those also. Like they can learn dobutamine stress echoes and transesophageal. It's a free hand. So basically these normal 2D echoes, I give them a free hand. Like they can hold the probe. I teach them how to hold the first week will be like just they have to observe what I am doing, where I'm keeping the probe, what dimensions I'm taking, what measurements I'm taking, how I'm taking, where am I keeping the probe, whether it is in the second, how I'm making the patient lie down. All that will be taught in the first 5 days. Mm-hmm. After that, like if they are smart enough or if they can handle it themselves, I just allow them to do the whole report. Like they are reporting completely. They keep the probe, they see. And Dr. Shravani, the thing is like there are many programs going on. Like you have these online programs of Thomas Binder and where you don't have a touch with the patient. Like you don't know how to hold a probe and all. He tells you on the video, you have to just look at it and try to do it. Yeah. But what we have seen here is even those people who have undergone such type of trainings online, they are unable to hold the probe exactly like where it is, because practically something different from theory. Yeah. When you touch the probe, when you have the feel of the patient, when you have the feel of the skin of the patient or the machine, only then okay where you are supposed to keep the probe or what position your probe has to be kept, and what are the tips and tricks of keeping the probe. Like you keep it like this, it becomes oblique. You keep it like this, it becomes flax view, and that comes with the contact probe.
Practical training, right?
Practical training. Practical is something different from your theory. Theory, you have many books. You have Figgenbaum, you have Tajik, you have so many books. You can read them. But then when it comes to practical, when you really want to keep the probe, they don't get windows. They feel that, okay, now we know everything, theory classes are over, so we can do everything and all. Once they start keeping the probe, they know that no, it's so difficult to get a window or an image. So these things, with this contact program, I think they can learn better. They can hone their skills better in contact program.
Right, Dr. Sajida, that's very nicely put. Also, Dr. Sajida, many of our students, some of them in the chat box today, or many more who will view this video tomorrow, all of us could be practicing somewhere as clinicians in a hospital or in a clinic. We must have seen a lot of 2D echo reports in our hand. Some cardiologist has done it and the report comes, the patient brings it to it. How many of them do you think actually interpret the report right? And what is your idea about interpreting a 2D echo report without an understanding of how an echo is done?
That's what I told you. It's very difficult. See, you don't know what is an echo report. That's what I told you in the beginning of a diastolic dysfunction. You don't know what is diastolic dysfunction, and suddenly you panic about, oh, this patient is having some heart problem. Try to admit him and do some more investigations and all, when you don't know the report. But when you know the report, when you are trained well in the 2D, even though it is 15 days contact program, doesn't matter. But when you know how to interpret the report, then these things don't happen. These panicky things, or when you have to panic. Okay, somebody writes there is a massive pericardial effusion. Okay, you don't know what is pericardial effusion, massive. You don't know how much of the fluid is massive. Then you don't panic. You just like, okay, maybe some fluid collection like ascites or normal pleural effusion like that. You just try to ignore it. But when you know that pericardial effusion, there is a tamponade, somebody writes that there is a tamponade, okay, you know what to do further. These are all some of the things like where you need to know the report, like even without doing, at least to interpret the report is also important. Somebody writes that there is a clot in the LV. Okay, I mean, some people, most of them may be knowing it and all, but when it comes to proper interpretation, I think some sort of program is required to interpret the report.
And many of us, we see a lot of duty doctors and medical officers and residents who are posted in the hospitals, who are the actual people who spend most of the time in the wards, more than the consultant, because the consultant is going to different places. It is the residents who spend most of the time, and it is the residents who receive the reports first in their hand before the consultant sees them during the next morning rounds. So it's always important for all these duty doctors and residents also to know, because
in ICUs and all, like suppose I go and write a report, I tell the resident there, or if he himself is telling that this patient is breathless and we are suspecting some clot, you see that clot there sitting at the pulmonary valve. Okay, that resident, he knows, like he has to immediately inform the consultant that there is a clot here in the pulmonary artery. Okay, if you don't know how to interpret that report, the patient may die of embolism.
Right. And we might even communicate the same wrong message to the inquiring patients and attendants as well. Yes. Most of the times these days, patients tend to, attendants force us to show them the report. What is the result of it? And then they read, and just like you said, they might read out a dysfunction and say, oh, there is something wrong, So I think a basic understanding of interpreting the report is very important. And as you correctly mentioned, Dr. Sajida, what we learn in theory is entirely different from how to identify it on a report paper. I might define a pericardial effusion, but what is considerable on a report is something only you will be able to train me and teach me. Absolutely.
I know mitral stenosis, but what is written on the mitral stenosis, like, okay, something is written like Wilkins score or something like that. So you know when to send the patient where to send the patient, whether you are referring the patient as a physician, you have sent someone for an echo report. Then that echocardiographer or cardiologist reports it as severe mitral stenosis with so and so severe MR. If when severe mitral stenosis with severe MR, the patient has to be referred to the CT surgeon. But only if it is severe MS, the patient can be referred to a cardiologist, interventional cardiologist. So this you won't be wasting the time of the patient and unnecessary consultations and all. Once you know that this is severe MS, severe MR, okay, the patient has to go to the surgery, so it goes to the CT surgery. This is where your skill lies.
Right.
You need to know how to interpret a report. This 15 days, okay, maybe not as you may not become perfect in 15 days. Maybe the students who are listening may not become perfect in 15 days, but then at least they'll become smart enough in 15 days, like to know what is what.
Yeah. So, Dr. Sajida, it's been now, 3 years that Medvarsity has been running this course, and you're closely associated with us for training.
It's more than 3 years.
2014 March, probably. So, we've enrolled almost 300 students, and I think you've trained around more than 100 students in the clinical training. So tell us about your experience, about what sort of students come to you and how they learn and how did they give their feedback afterwards.
My students range from post-MBBS to post-MD anesthetists. In fact, some 2-3 gynecologists also, because they felt like, okay, echo must be known and all for their patients, and at least in case of emergency and emergencies. So I have trained about more than 100 people, I believe, and everybody, touch wood, everybody is doing well, everyone. And it's not that, okay, this is just a 15 days program, how should I practice and all. Some of them even have got their own machines, have their own setup, and they are practicing. Some of them are in the corporates doing 2D echoes.
Right.
But most of them have got their own, have started their own clinic with 2D echo, and they're doing well.
Right. But then to start up their own this thing, isn't there an additional qualification required, and are there some rules, Dr.
No, I don't think so, because I think 3 of my students in Maharashtra, they have started this with this qualification only. They have started a 2D echo clinic, and they are doing well. And with the cases, they have referred to the consultants, sometimes CT surgeons and all, like I told you, mitral stenosis and all. Even they were applauded for that.
Right.
Right. CT, and also like just being a post MBBS, like how could you diagnose this, and you could send to us.
Right.
Last time in Pune, that one of my students, he diagnosed an ASD, and I mean that was little critical and all, and he referred the patient and all. So the doctor was really applauding him, like, okay, that's great, like you're doing a great job.
Right. Dr. Sajida, a student also posted a question on this page also, saying that, not in the chat box, below in the questions, the question is something like this. I'll read out the question for you so that we can address him and it'll help him. So he says, does a non-cardiologist have legal or ethical right to do echocardiography, assuming he or she is trained in the subject? And will this report be acceptable to the cardiologist in the community?
See, it all depends upon the accepting of the report. It's how well you are trained or how well you are doing. Even here in the hospital, when we have 3-4 reports, like people tend to believe one person. Okay, this person's report is good. Go to him, go to her. So on that matter, I can't comment anything because it's our individual perception. So some consultant may feel that, okay, she's doing well, send the patient to her, in spite of we having 4 or 5 echocardiographers here. So it's all individual perception.
Right. And many times this question arises, Dr. Sajida, when students are inquiring about the course that, outside, if they perform an echocardiogram, they do an echocardiography and they report it, are they legally allowed to sign that report?
Yeah.
And what is it that they need to be?
No, what is the doubt in signing the report? Like if you are so, confident about the report, you are confident that, okay, the report is right. See, as far as you are not harming the patient, there is nothing wrong in doing anything. You know your limits, you know your abilities. You know that you are doing a good job. You know you are confident about the report, that the patient didn't have any problem, like it was a normal echo report. There is nothing wrong in signing it. But when you have doubts, it's always to take a second
opinion. Right. So Dr. Sajida, for all the students who are attending the session today, if you can give an advice about, so we are talking about our program, which is a 6 months course with 15 days of clinical training that is attached. So you have to talk about the program because you've been so far associated with it for the benefit of the participants today. What is it that you would like to give the message to these students about this course that we do?
So the message is that when every knowledge is helpful, whatever it is. For me, I believe that even if I read a newspaper, I'm reading something new article, it's beneficial. For that matter, in medicine, you have to upgrade yourself, whatever it is. You have to upgrade. Whatever is new in the field, you learn. Like even I see my teacher, like who is almost 70, 80 years old, like my mentor or teacher, cardiologist, he keeps reading every day in spite of his age, and he doesn't know, okay, I'm old now, I don't need to read, or don't need to upgrade myself. Every new thing comes, he reads. He tells me the articles. So in medicine, it's nothing like, okay, you're stagnant here, you know this much, you're past your MBBS, you stop it here. It's nothing like that. You have to upgrade yourself. Okay, there is nothing wrong in knowing an echo. There is nothing wrong in knowing the ultrasound. Nothing wrong in doing FCC course, like what we have started, that cardiology course also. That's also good. That's also good.
Yeah.
So nothing wrong in learning echoes. What's wrong in that? You learn something from it.
Right. So now that you've mentioned our clinical cardiology program also, Dr. Sajida, so this fellowship in clinical cardiology, we're doing in a 1-year online course with 3 months of clinical attachment. So students have a lot of doubts and questions about what will I get to learn, in these 3 months of time.
These 3 months, what we are teaching them is we are teaching them full echo. This 2D echo program is there where they learn only echo. But in this 3 months program, we are teaching them echo, we are teaching them TMT, we are teaching them basics of ICU management, basics of emergency management, plus the OP cases.
Right.
So, yeah, the period is short, but in that short period, we are covering everything. They are posted 15 days in each department.
Yeah.
They learn everything. That's a different program altogether. We are basically concentrating on 2D echo now.
Let's talk a little about the career prospects, Dr. Sajida. I think everything boils down to that. But I understand with 2D echo, I think wherever we are, we need to upgrade ourselves and get, understand how echo works. That's a different thing. But a lot of times students want to ask if somebody is trying to get into a job or something, or, they want to move to a different city or hospital. Repeatedly, they ask me this question, ma'am, if I do this course, what value will it add to me and what sort of career prospects will I have?
Anything when you are upgrading yourself, that is an added feather in your cap, right? Anything what you do. So it may at least give a better this in your CV. Like I can do echoes. That makes a much difference. And plus, we here have hired, one person. After this, we have taken job opportunity. There is a job opportunity. It's nothing like, okay, you don't get any job opportunities or anything like that. Of course, we identify the best person here. Whoever is doing well echoes, we give them an opportunity to join us. This has been since last 2 years. We always ask that whichever group of 2D, we ask them whether they want to join us or not. But most of them are from outside. They go and they're doing well.
Yes, they go back to their own practices and
they go back to their own practices, and they have their own machines. They're having their own clinical setup or hospital and all, and I think everybody is fine with it.
Right. Dr. Sajida, repeatedly, one more question that I get to be asked is about the hands-on experience. Now, you've already clearly explained that first 1 week would be more of an observership, and the second week, if they're confident enough, you will be giving them a free hand. Can you
even confident? I try to teach them, to hold the probe and just do it hands-on. It's not that we are not giving hands-on. For every person, we are giving hands-on.
Right. So because the doubts they ask is, would it be just me watching a consultant do an echo, or will I also be allowed to do an echo is what they keep asking.
No, they'll be allowed to. Definitely they'll be allowed.
Right. And one more question that I found in the chat box, Dr. Sajida, I'm just scrolling up. There is this Dr. Megdeep who asked, would pediatric echocardiography, including M mode, be covered? He said, would pediatric echocardiography, including M mode, be also covered? I said specific pediatric echo is not done here.
We do all congenital cases and all we do, but adult congenital cases, pediatric we don't do.
Yeah.
We have a separate department for pediatric cardiology.
Right. So I think that has answered Megdeep's question. Yeah. So Dr. Sajida, so as a trainer so far, training more than 100 students here at Apollo, and you've seen their experience and how they've done. So if today any of these students is trying to make a decision, should I join this program or not? What is it that you can tell them from what you've seen over the years?
Yeah, before the program finishes, let them join.
Right. So students, let's take some questions, guys. Megdeep, Senthil, Vanita, and Sokle, Saujanya. If you have any questions, please type in the chat box. Dr. Sajida would be more than happy to answer your questions because it's more about interaction. So if you have any questions, please post in. So Dr. Sajida, thank you so much.
When should I join?
When should?
What is the next date to be joined?
I think it's immediate because one thing I wanted to mention to all the students, I think Sajida, you're also aware, this GST is getting added. So from tomorrow, July 1st, the additional sales tax is also effective. So today,
the program also?
Yeah, all the courses and all the programs will be having that GST added up. So it's a good opportunity for students. You know, they've listened to you, they've gotten their questions answered. So if anybody is trying to make a decision, economically also it's better today. And any more questions, you can please post in the chat box. Otherwise, if you have any questions, please feel free and forward it to Medvarsity. We'll be happy to get back to you and answer you. Thank you so much for joining us, Dr. Sajida.
Thanks, Dr. Shavani. Thanks for inviting me. And probably next session we'll call our students also who have let them join here so they will know.
Yes, they will also speak about their experience. And before closing in, one last thing, it happens to be incidentally Doctor's Day tomorrow. So I would like to congratulate you, ma'am. Congratulations for all that you have done so far in your department. Thank you so much. And I hope you continue to train many more people like you and many more of our students. Congratulations, and we'll see you next time. Bye.
Thank you.
Bye-bye.
Bye.